So I want to introduce today's speaker. Dr. Pearl Chang is a pediatric hospitalist at Seattle Children's Hospital and assistant professor of pediatrics at the University of Washington. Her scholarly interests are neonatal jaundice and infections in young children. She recently co-led a national quality improvement project to implement the 2022 AAP Jaundice Guidelines. Outside of work, she enjoys trying new restaurants and learning new crafts. And I'll hand it over to you, Dr. Chang. Thank you so much for joining us this afternoon.
Thanks so much, Erin. Thanks everyone for spending your noon hour with me to talk about the 2022 Jaundice Guideline. Unfortunately, I can't see any of you, so I would love to actually know who's out in the audience today. So if you are able to type in the chat, who you are, and specifically, I'd love to know what kind of clinical work you do, whether you're outpatient, inpatient, a little of both. I can sort of try to tailor the talk on the spot to make it relevant for you. As Erin mentioned, I will try to address as many questions I see pop up in the chat box as I can during the talk. If I can't, I promise I'll get to at the end, and please don't be offended if I am not able to get to your question in real time. All right, well, let's get started. If I can get my slides to advance. There we go. So the obligatory disclosure slide, I do not have any disclosures. I did want to start off with a couple acknowledgements to Dr. Lisa Hampton at UVA Children's Hospital and Dr. Caitlin Wimmer at Children's Hospital of Colorado, who helped me develop the original version of this talk. So obviously all of you have been using the 2022 jaundice guidelines now for a couple years. And so my intention today is not to go over every single recommendation one by one, but to discuss the evidence behind some key updates in the clinical practice guideline, or CPG. And in doing that national quality improvement project to implement these guidelines, I heard a lot of points of confusion from the participants, and so hoping to clarify some of these points for you here today, and then to offer some tips for practical application of the CPG in the clinical setting. So this is just a brief outline of the topics I'll discuss. I'll start with some of the rationale for the updates, review some of the changes, and highlight the key topics listed here. So let's start with the rationale. As all of you know, the last clinical practice guideline for neonatal jaundice from the AAP was published in 2004. So one of the obvious reasons for the updated guidelines is now we've had 18 years of new evidence on the treatment of jaundice. And of course, the feared complication and the reason we treat neonatal jaundice to begin with is to prevent bilirubin neurotoxicity, or more commonly known as kernicterus. And there have been several large cohort studies examining this since the publication back in 2004. This figure, which I'll also come back to later in the talk, is from a very large Kaiser Northern California study of a little over 500,000 newborns from the late 90s to the early 2000s. And what they found is of these 500,000 newborns in this cohort, there were only 47 newborns with a peak bilirubin above 30. And so these are all the various dots that you see on the figure here. And 4 of these newborns had signs of acute bilirubin encephalopathy. So that's the 4 that you see with various circles and diamonds and triangles. And 3 of those 4 went on to develop chronic bilirubin encephalopathy with cerebral palsy and or hearing loss. And a couple things to note is that each of these newborns with bilirubin encephalopathy had peak bilirubin levels far above the 2004 exchange transfusion thresholds and had significant risk factors, including hemolysis. And in fact, they found in longer term studies that there were no cases of chronic bilirubin encephalopathy found in babies with peak bilirubins between 30 and 35. And so this very low incidence of hazardous hyperbilirubinemia, often defined as a bilirubin above 30, is one reason for the slightly raised phototherapy thresholds in the new guidelines, which we'll talk about in just a few minutes. Outside of frank bilirubin encephalopathy, there have also been several studies that looked at isolated outcomes of cerebral palsy or hearing loss. And they found that there was an increased risk of these outcomes only at bilirubin levels at least 5 milligrams per deciliter above the old 2004, again, exchange transfusion thresholds, and no associations of these outcomes with lower bilirubin levels. There's also been studies that show no evidence in using phototherapy to prevent newborns from reaching modest bilirubin levels to prevent other more subtle outcomes like asthma or autism, for example. And so it's clear from the 2004 treatment thresholds that there is definitely over-treatment of neonatal jaundice. And a lot of people think, well, who cares? It's just some phototherapy lights. But there's also associated risks. So I think we think of cost, right? Length of stay in the hospital, potential separations of moms and babies, depending on your hospital setup, potential impacts on breastfeeding. But a study also has found a small associated risk in lifetime risk of seizures, especially in boys. And so this figures from that paper, which shows the cumulative risk of the outcome of an encounter for a seizure with an anti-epileptic prescription, stratified by whether or not phototherapy was received. And so that top higher line was if you received phototherapy. And then lastly, I wanted to point out that the 2022 Hyperbilirubinemia Guidelines was the first CPG published by the AAP after its release of a policy on eliminating race-based medicine, which was published just a month prior in July 2022. And so an example of this from the 2004 Hyperbilirubinemia Guidelines is from on the left there. And so what we know is that when we review the kernicterus registry, Black newborns actually make up 25% of the reported cases of kernicterus in this country, but only about 14% of births. And this is, of course, likely due to a number of biologic and non-biologic factors. But one non-biologic factor is the misperception that Black newborns are actually at lower risk for hazardous hyperbilirubinemia. And the 2004 guideline on the left, unfortunately, reinforced this misconception. So it included a list of risk factors for the development of severe hyperbilirubinemia. And they list in this major risk factor East Asian race. And as a risk factor on decreased risk of significant hyperbilirubinemia, they actually list Black race. And so this assignment of lower risk may have decreased the urgency of diagnostic evaluation in those Black infants. An important biologic factor, which is really stressed in this new guideline, I'll come back to, is G6PD. So approximately 12% of African American males and 4% of African American females have G6PD deficiency. And together they count for about 3/4 of all the individuals with G6PD deficiency in the US. And so the 2022 guidelines specifically do not include race-based factors in its risk assessment or management of jaundice, but they do make an explicit statement about the awareness of family history or genetic ancestry as might be suggestive of an inherited red blood cell disorder, such as G6PD deficiency. And again, we'll come back to that in just a little bit. All right, so let's discuss again some of these key changes and how they were made. And so as all of you have now seen by now, these are the new phototherapy thresholds. And so I want you to go over how exactly the guideline authors came up with these new thresholds. So what they did was they took the 2004 thresholds for the 40 weekers and raised it by 2 milligrams per deciliter. Then they took the 2004 guidelines for the 35 weekers and raised those by 1 milligram per deciliter. And then they more or less evenly spaced out the thresholds for the 36 to 39 weekers between the 35 and 40 weekers, so that now each gestational age has its own phototherapy curve. And so you can see this is not entirely evidence-based. This is still very much expert opinion and arguably a little bit arbitrary. A common question that's come up is, should you be using the birth gestational age? Yes, that is how the guideline authors intended. And the reason is because they actually take the chronologic age into account when they built the phototherapy thresholds. So you can see, for example, if you look at the 39-week curve, which is that dotted orange line here, you can see that they start merging with the 40-week curve because they're assuming the 39 weeks will turn into a 40-weeker. And so that curve merges at 7 days right around here. And so this graph, of course, as it says, is for infants with no hyperbilirubinemia neurotoxicity risk factors. This is also the one to use if gestational age is your only neurotoxicity risk factor. If you have neurotoxicity risk factors other than gestational age, you would then go ahead and use this curve right here. And you can see that this curve is missing the 39 and 40 weekers because anyone less than 38 weeks is considered a gestational risk factor for neurotoxicity, and so they eliminate the other two gestational ages here. I will also just quickly point out this new term, escalation of care, which I'm sure you've heard, and this is a new term for 2022, where when you reach 2 milligrams per deciliter or within the exchange transfusion threshold, then the AAP at this point recommends more intensive therapy like IV hydration, additional labs, more frequent bilirubin checks, and transfer to a location that could perform an exchange transfusion if needed. This has also brought up several questions from people who aren't necessarily practicing in a hospital with a readily available NICU, is how urgently they need to transfer these babies. And I think the idea here is that the AAP just wants you to prepare for the possibility of more intensive care that you may not be able to provide locally, but certainly you should get that phototherapy started as soon as possible. And with the great phototherapy equipment these days, you likely can get that bilirubin lower than this exchange escalation of care thresholds, and potentially be able to avoid a transfer oftentimes. All right. In the 2022 guideline, the AAP also slightly revised its list of neurotoxic risk factors. So on the left is the list from 2004. And essentially what they did was they combined a few things, specifically asphyxia, significant lethargy, temperature instability, acidosis, into this more general term, significant clinical instability in the previous 24 hours. Otherwise, the rest are the same: hemolytic disease, sepsis, and albumin less than 3. So this also caused quite a bit of questions about what exactly constitutes as quote unquote significant clinical instability. And the way I like to think about this is to remind myself of how bilirubin causes brain damage in the first place, where you have to have a sufficiently high level of inbound bilirubin that then crosses the blood-brain barrier. And this equilibrium between bound and inbound bilirubin is affected by a few things. This includes the albumin concentration, and the albumin bilirubin binding capacity and then in return reduced in infants who are ill or unstable. And if they got some sort of medication, for instance, and therefore you have presence of competing compounds for your albumin. And so most of the scenario I would say that we encounter are probably not significant instability. In other words, if you have a truly sick infant in the NICU, you'll know. But most of the newborns who are in the NICU for whatever reason, so for example, if they needed a few hours of CPAP after birth and after that they were well, or if they in fact had blood sugars that were so low they needed IV dextrose, but there was a good reason the birth parent had suboptimally controlled diabetes, these infants are probably not sick enough to be constituted as significantly unstable. Similarly, all those infants who needed to rule out sepsis for whatever reason, but clinically you actually have a fairly low concern for sepsis, probably isn't sick enough to affect this entire sort of blood-brain barrier bilirubin binding equilibrium. And so these are probably not what the AAP had in mind when they said significant clinical instability. A common question has also been, should albumin then be checked in every newborn since it's listed as a neurotoxicity risk factor? Well, it was also listed in 2004, and similar to the 2004 guidelines, the AAP does not, in fact, recommend a routine albumin check in all newborns. This question came up so often that the guideline authors actually made a website with some frequently asked questions that you can find if you go to the 2022 guideline. And so on there, they write that albumin does not need to be measured unless there is reason to suspect it would be low or the baby reaches the escalation of care threshold. So that's one of the labs that they do recommend checking if you reach that threshold. Hot off the press this month in Hospital Pediatrics, published I think just a couple days ago, was a study done in Thailand. They had almost 1,000 newborns where they did in fact routinely check an albumin level in every one of these newborns. And they found that an albumin level less than 3 was actually fairly common. So about a quarter of the newborns had an albumin less than 3, but it very rarely affected decision making ultimately. In other words, usually there was either some other factor that would have led them to phototherapy anyway, or the bilirubin level really never got high enough that even having a slightly low albumin affected their decision of whether or not to start phototherapy. Also, just recall, if you look at sort of the two curves of neurotoxicity and non-neurotoxicity curves, the difference between the thresholds are really only about 2 to 2.5 milligrams per deciliter. And so even if you might have used the wrong curve, you're likely not going to make a huge difference in the overall clinical outcome of the baby. All right, what is heavily emphasized in the new guideline, which was not as much in the 2004 guideline, is this evaluation for hemolysis. So I'm coming back to that study that I mentioned at the very beginning, where the Kaiser Northern California cohort of about 500,000 newborns, I mentioned that there was 47 who had a hazardous hyperbilirubinemia level or a TSB greater than 30. And so what you can see from table 2 of that study is that most of the time they couldn't identify a cause for why they had such a high bilirubin level. But of the cases where they could identify the cause, the most common reasons were G6PD deficiency and DAT positive or Coombs positive isoimmune hemolytic. And then of those 4 infants that you recall who actually went on to develop kernicterus, you can see here in table 3 that, first of all of these 3 infants had very high peak bilirubin levels above 40. And what's notable is if you look at this G6PD activity here, 3 of the 4 infants had G6PD deficiency. 1 was not tested, so we don't know. And may very well have had G6PD deficiency as well, but 3 of the 4 had G6PD deficiency in this particular cohort. And so the new guidelines recommend evaluation for hemolysis in a number of different scenarios. This is figure 1 from the 2022 guideline. And this has also caused quite a bit of confusion, where this box here, and if you sort of skim it left to right, kind of makes it seem like you're supposed to be doing this for every DAT positive newborn, where you're checking bilirubins a lot after birth. That's actually not what this figure is intended to say. And so I've sort of reworked the figure. And so this is sort of my reinterpretation of it. I will note that it is not AAP endorsed. But the figure is actually trying to do is to stratify between if you have maternal antibody positive or unknown, or if you're maternal antibody negative, and how you proceed from there. Okay, so if you have a mom who is maternal antibody positive or did not get prenatal care, or you don't have the records, and so you don't know what the maternal antibody status is. What the figure says is that they recommend you get an infant DAT and blood type as soon as possible. So for instance, get it from the cord blood. And then if the infant is DAT positive, and you know that this is not just from a passive transfer ROGAM, or you can't tell, so for whatever reason, for example, your lab is not able to tell you if this is passive transfer or not, then this is when the AAP has this new recommendation of saying you should get either a transcutaneous or serum bilirubin immediately after birth, or as soon as possible after birth. Then they want it every 4 hours times 2, then every 12 hours times 3. Okay, so this is really the only scenario where they recommend this. If you get the infant DAT and the DAT is negative, or the DAT is positive, but the blood bank tells you it is just from passive transfer of ROGAM, then you do not have a neurotoxicity risk factor and is just routine care. The confusion here comes in this sort of bottom line. So if you are maternal antibody negative, but you have a DAT positive infant from ABO incompatibility, this is probably by far the most common scenario that we encounter. While this is a neurotoxicity risk factor, figure 1 does not, in fact, recommend all of this. It is just under routine care. So you would just get your bilirubin check whenever you normally get it checked. So whether you do it at 24 hours or 18 hours or whatever, your typical routine is in the nursery. Okay. All right. This has also led then to a couple of questions about the DAT. So some questions we heard is, what if my hospital does not do routine blood typing and DAT testing on all newborns? And I would say that is totally fine. If you read the guideline, they essentially recommend a DAT when you are starting to get concerned that there is some sort of hemolysis going on, if the baby needs phototherapy, certainly if they reach escalation of care. And the reason is because the predictive ability of the DAT for active hemolysis is actually quite limited, and the positive predictive value is not great. It was 60% in one study. There's been others that have done a little bit lower, a little bit higher. And so what I personally usually do is if you are not a hospital that routinely gets blood typing and DAT testing, then if you are at the point where you are nearing phototherapy threshold, you're rechecking serum bilirubins, that's when you probably should get that blood typing and DAT done. So you make sure that you use the right threshold. The other questions come up is, let's say the baby is DAT positive, but it doesn't seem like they're actually hemolyzing. Do you still have to use that curve, that neurotoxicity presence curve? And then the answer there is that if you do in fact have DAT positive ABO incompatibility, so you actually have differing blood types, not just this passive transfer from ROGAM, the intention of the guideline authors is, yes, you're supposed to still use that neurotoxicity curve and therefore the lower phototherapy thresholds. That being said, again, the difference between the curves in its phototherapy threshold is about 2.5 milligrams per deciliter. And so if you really feel like this is a DAT positive infant, they're not hemolyzing, you want to use the other curve. I'm sure that, again, in the grand scheme of things, the clinical outcome is not going to be drastically different, but just realize, of course, that the guideline author intended to be using the neurotoxicity risk curve. All right, what about G6PD? I promised that we would come back to that a little bit. And so again, this particular new guideline really tries to move away from race as a social construct dictating care, emphasizing that race is different from genetic ancestry, and to focus on genetic ancestry or ancestry and genetics in its assessment of G6PD risk. So asking questions, for example, like anyone in the family who ever gets jaundice with certain foods, things like that. And so the guideline recommends G6PD testing if there is one or more of the following, and importantly, unknown etiology for hyperbilirubinemia. So if you know the baby is DAT positive with ABO incompatibility, they would not follow, or they would not fall under this. They do not necessarily need G6PD testing. But if you don't know why, and you have a baby who meets phototherapy thresholds at less than 24 hours of age, if you have a baby whose bilirubin is in fact increasing under phototherapy, if you have a baby who reaches, again, that escalation of care, that new term, or if you have a baby who you feel has atypical development of jaundice, so for example, an exclusively formula-fed baby who is needing phototherapy, this is mentioned specifically in the guideline a couple times, then the guideline does recommend G6PD testing if you don't have any other reason for any of this. They do also note that you could potentially have falsely normal results during a hemolytic event. And so if you do have a high suspicion, you may need to retest that G6PD level sort of after, in a little bit after you think this hemolytic event is done and the bilirubin has now come into sort of a normal range. All right, lastly, not in the AAP guideline itself, but has had a couple studies from this author right here, Dr. Christensen, who is a neonatologist and hematologist. He has postulated for quite some time that hereditary spherocytosis might actually be the cause of some of those hazardous hyperbilirubinemia and potentially kernicterus, where the cause is listed as unknown. And so he published a couple studies where he advocates for screening for hereditary spherocytosis using the MCHC value. So I'm just throwing this in here because if you're getting a CBC for a baby, getting phototherapy or having a high bilirubin level, glance at the MCHC and see if it's 36 or above. Based on his studies, this could indicate possible hereditary spherocytosis. So I do this every time, and I will say I haven't had many over 36, and the one I had, I sent for hereditary spherocytosis and they did not have it. But an interesting study and something just worth considering as we sort of really focus on hemolysis as a huge risk factor behind these high bilirubin levels. All right, I'm going to switch gears a little bit here on these very new guidelines in 2022 about stopping phototherapy. This has also caused quite a bit of sort of concern and confusion. And so I'm going to start actually by reading a text that I received from my colleague who may look similar to something you've received or sent out if you do newborn care since the new guidelines came out. So my colleague texted me, I have a DAT positive baby who started on phototherapy at 20 hours of age for a total serum bilirubin of 12. The bili hasn't continued to rise and is now 9.5. The initial light level was 9.9, and I know the new guidelines say to consider discontinuation when 2 below initiation level. Light level for the current age would be 16.5. And the colleague says, I guess I'm confused. I mean, this baby probably has a level of ongoing hemolysis and risk of rebound, but do I really need to keep this kid still on lights until I'm able to drive down even lower because it's been a couple of days of phototherapy? And so what I say every time is that guidelines are guidelines, and you absolutely do not have to follow it to a T. So you do not have to wait until the bilirubin is exactly 2 milligrams per deciliter below the starting threshold for every single patient. And then if you read the guideline closely, it actually says that this is, quote, an option. The reason that the AAP chose this, again, semi-arbitrary threshold is because based on a, again, cohort study, the estimated rebound risk is about 2.5 to 10%. So what this means is if you were to drive the bilirubin down until it is 2 below the starting treatment threshold, then the probability that the baby would reach phototherapy threshold again in the next 72 hours after you turn off the lights is about 2.5 to 10%. And this is sort of what the guideline committee thought was appropriate. As you're trying to decide when to stop phototherapy, if you're not, going to stick to this exactly, I think there are several factors to consider. And so one, of course, is what is the etiology of hyperbilirubinemia, right? If you have ongoing significant hemolysis, that's very different from your baby who you're putting under lights because they just had a lot of weight loss. And that then, is kind of probably case number one, right? This baby exceeded threshold less than 24 hours of age, is DAT positive, so they're probably hemolyzing. And this is why it's so hard to get it to 2 below the starting threshold. But let's say you have a different case, right? This is the 39-weeker who started phototherapy at 96 hours of age. And so the threshold here is at 21.5. Okay. And now let's say after 24 hours of phototherapy, it was 19.5. And even though it is now 2 below the starting threshold per the guideline, you could technically stop your lights. This is actually kind of weird because, as most of you know, these sort of babies, the 96-hour-old 39-weeker is usually getting phototherapy because they have some sort of suboptimal intake, and usually the bilirubin falls really quickly after just a few hours of phototherapy. So that would actually be kind of strange. And the difference again between this 96-weeker and this 20-weeker is that this one, of course, is sort of nearing or potentially passing its physiologic peak after a day of phototherapy. And so in this first baby here, if you were to stop phototherapy a little sooner at, say, 48 hours, you would probably have a different risk than if you were to wait until 72 hours just because of where the physiologic peak sort of lands. And of course, there's like social factors, right? Is follow-up difficult for the family? Is readmission difficult for the family? Do they have transportation issues? Is it actually harder for them to be readmitted than to stay another day? So these are all considerations, of course. And so I would like to propose then a few alternatives to stopping phototherapy that are, again, not AAP endorsed, but things to consider if you don't want to wait until the bilirubin level is exactly 2 below the starting threshold. So this first bullet here is actually what I most commonly do when I'm in the nursery, which is that I stop phototherapy when the bilirubin is 2-ish below the starting threshold. So what I mean by that is, let's say I get my morning bilirubin after a day of phototherapy, and it is now 1.5 below threshold. I wouldn't necessarily wait until it's exactly 2. And again, I think about where the physiologic peak is, ability for follow-up. But at that point, if I feel like the bilirubin has had a good drop, I probably would just stop it. Okay, another alternative is, let's say you and your colleague don't love the AAP guideline, but you're trying to be more uniform nonetheless, rather than this 2-ish thing going on, is that you guys could have just agree to stop it at a different level and acknowledge that there is either a higher or lower bilirubin risk. So what I mean by that is you could all decide, well, we're going to stop phototherapy when the bilirubin level is at least 1 below the starting threshold, and that certainly would work fine as well. Lastly, if you are someone who likes to play with calculators and probabilities, you could actually plug in a few values into a rebound calculator and decide what is a susceptible rebound probability for you on a case-by-case basis. So one particular calculator that we developed in 2017 uses the difference between the current bilirubin level and the current treatment threshold. You can find that just by doing a little Google. I will say both prediction models, so this particular one, as well as the one that the AP used to develop their recommendation, both have limitations and both likely underestimate the rebound risk for infants who have severe hemolysis. So for example, if this were an Rh negative ICE immunization, these calculators unlikely actually predict the true rebound risk. All right, so you've stopped your phototherapy finally, you've decided. When should you then get a rebound bilirubin? And this, again, are some new recommendations in 2022. Briefly, this is what the new CPG recommends. They stratify based on whether phototherapy occurs during the birth hospitalization or during readmission. And during birth hospitalization, you would get a bilirubin either 6 to 12 hours after stopping lights, and again the next day, or just the next day. If it's a readmission, then you would get a bilirubin either the next day or in 1 to 2 days. I will say personally, I don't actually love the way this is stratified because I feel like there's a couple potential fallacies with this recommendation. So one example that comes to mind is, let's say you have a 44-hour-old baby who starts phototherapy. And so if this was just a routine vaginal birth, you may in fact have discharged this baby at 20 hours of age, and then they come back. And so this would technically be a readmission. And since this would be a first-time phototherapy, then you would say, okay, go get yourself a bilirubin or clinical follow-up only in 1 to 2 days. But let's say your 44-hour-old baby was still in the nursery because it was a C-section birth, or it was a vaginal birth, but mom had issues, right? But they were still technically in the nursery, so they would be birth hospitalization phototherapy. Well, because they're 44 hours old when they started, it would be less than 48 hours old. And so then per the guideline, you're supposed to actually get a bilirubin 6 to 12 hours after stopping. And it just doesn't make sense to me why the rebound bilirubin follow-up would be so different for this 44-hour-old, potentially just based on the type of birth. I also personally find this whole tree a little bit hard to remember. And so, again, I'm proposing an alternative algorithm that is not AAP endorsed. I just like to make that very clear, where essentially you just say, is this baby at a high risk of rebound bilirubin and therefore needing phototherapy again? And so what studies have shown that is that if you do start phototherapy less than 48 hours of age, or you think you have hemolysis, so the baby is DAT positive, or some other suspected hemolysis, you are at higher risk. And so I would say at this point, you could consider a rebound bilirubin 6 to 12 hours after stopping. And this depends a little bit on what your ending bilirubin is, the rate of bilirubin decline, again, that physiologic peak, social factors, and then again the next day. I will say typically I personally do not get a rebound bilirubin unless I truly think there is severe ongoing hemolysis. Generally, I drive down the bilirubin to that 2-ish below the starting threshold, and then I have them get follow-up the next day. And then for all other infants who you do not suspect some sort of hemolysis, who did not start phototherapy at a young age, then in 1 to 2 days should be okay. Just a quick note here, this was buried a little bit in the CPG, and this new recommendation here is that you can get, if you have access to a transcutaneous bilirubin, you can use that if it has been more than 24 hours since stopping phototherapy. And so this is a new recommendation since 2004. I will just quickly note that the correlation between your transcutaneous and serum bilirubin levels are generally within 3. But this correlation does drop off once the bilirubin reaches mid-teens, particularly 15 in this particular study here. So just keep that in mind if you are going to be using a transcutaneous bilirubin before or after phototherapy. All right, the last thing I'll talk about is the new recommendations for follow-up after birth hospitalization. So as you all know, the beloved Bajani nomogram is now gone. And in its place is this table here, figure 7 from the CPG. And a couple of things to note. One is that this is for infants who have not received phototherapy. Okay, so if they receive phototherapy, you get to use that complicated tree for when to check a rebound bilirubin. This is follow-up if you have not received phototherapy. And if you're wondering why the recommendations range from getting a serum bilirubin value in 4 to 8 hours, or follow up within 3 days, clinical judgment. This is why. This is also a study coming out of Kaiser Northern California. And the study looked at the probability of exceeding the phototherapy threshold within 24 hours of birth, hospitalization, discharge, 48 hours, or within 30 days of birth, hospitalization, discharge. And what they did is they broke down the delta TSB, or how far your TSB is away from phototherapy threshold, in these 5 categories. And so as you can see here, if your bilirubin is within 2 of the phototherapy threshold, the probability of reaching threshold within 24 hours is 29%, 46% within 48 hours. And so that's why the AAP recommends very close follow-up, especially if the baby's less than 24 hours old. And that's, again, when you suspect possible hemolysis. And then sort of, your probability goes down, down, down. And in this particular cohort, if you are within, or actually greater than 7 away from threshold, in this particular cohort, no baby actually would have reached the 2022 thresholds. And so the follow-up can be farther away. Of course, in reality, this is probably not true. And so that's why they still do recommend follow-up, but at least in this cohort, the risk was very, very low. So sort of the questions that have come up that I've heard is, one is, can this guide be used for follow-up in the primary care setting after discharge? And so this is also on that FAQ that the guideline authors put together. And essentially their answer is yes. And what they say is, in general, most infants in the first 5 days after birth, even as outpatients, should be similar to those still in the hospital. So the timing for follow-up for infants who have not received phototherapy, as described in the flow diagram, can be similar. And then they say additional clinical judgment is needed for infants older than 5 days. And the reason is because that Kaiser study only looked at within the first 5 days. And so beyond that, you're sort of on your own and making clinical assessment. The other then this leads to the question then of, well, how can we possibly get follow-up for a baby, say, in 4 hours as an outpatient setting? And I would say, again, go back to sort of what your risks are. Okay, so if you're within 2 and you're very early on in that physiologic peak, or very early on the first 24 hours, 48 hours, where you're truly concerned about possible hemolysis, yes, your risk is high. But if you're within, say 2 to 3.5 of phototherapy threshold, your probability of needing phototherapy is actually not that high. And again, think about whether you truly think there's hemolysis. If there is, they probably would have declared itself. If there isn't, you could probably wait 24 hours to get that follow-up. And so, saying they need follow-up in 4 to 24 hours, you can probably go 24 hours and not have to stress about doing it in 4 hours or 8 hours. All right. And so, in summary, the 2022 guideline really focuses on hemolysis as a significant cause of hazardous hyperbilirubinemia and chronic bilirubinemia, or kernicterus. It's really focusing on screening and evaluating for hemolysis as a key recommendation. I hope I was able to convey that there is room for individualization in the 2022 guideline. And I hope that understanding the evidence behind the guideline will then empower you to make treatment plans that are appropriate for your patients, even if it is not exactly what the guideline says. Well, thank you so much, all of you, for joining me. I hopefully have left plenty of time if there's any questions that have come up. And thank you for those of you who typed in where you're joining from. I do see a lot of outpatient physicians, so hopefully this was helpful for you as well. Thank you so much.
Thank you so much, Dr. Chang. That was a fascinating talk, and I'm sure very much appreciated by the folks who attended today. I did put the link to the evaluation in the chat box, so if you have a few minutes to complete that, we would appreciate that. I will also email that either this afternoon or tomorrow morning. And so you'll have an opportunity to get it there if you have to hop off now. As Dr. Chang mentioned, we do still have a little bit of time. So if there are any questions, again, you can put those in the chat box or go ahead and raise your virtual hand and we can unmute you. So we can just give it a minute to see.
Oh, thank you, Dr. Felt. Appreciate it.
Yes, lots of thanks in the chat. So I think you may have done such a good job that there aren't even any questions.
Ah.
So
Thank you, Erin. Sorry about that, but please do ask away if you have any questions or concerns about the guideline, because we've certainly heard a lot of concerns about why the AAP did this and why the AAP did that.
We'll just give it another minute. Oh, we have someone raise their hand. Sonia, I will unmute you.
Allegro Pediatrics. This was such a great talk. I really appreciate it. My question for you, Dr. Chang, is so on these kiddos that are DAT positive, you had mentioned that you can, in terms of checking the TCBs or TSBs in the hospital, they can be routine depending on however other babies are checked. I know different hospitals kind of have different protocols for them based on this these updated guidelines. So for example, like at one of my hospitals, we do Q12 TCDs. One of our other ones, we're talking about implementing a new policy for them. But do you feel overall the consensus is that Q24 Billies are appropriate?
Yes. My personal stance is that we overcheck TCBs for these DAT positive infants. One of my hospitals actually check at Q6 when they're DAT positive. And again, the DAT positivity actually being correlated with significant clinical hemolysis, the correlation is low. And so again, various studies have showed different things, but probably only about 20 to 25% of DAT positive infants actually have clinically significant hemolysis. So to me, checking a TCB every 6 hours, every 12 hours is probably excessive. That being said, keeping an eye on the baby's jaundice, just clinically is important, and definitely get that 24-hour check for sure if they're DAT positive. But I personally think the Q6, Q12 is overkill a little bit. But that's my opinion. The guideline certainly does just say routine care. So again, that figure 1 is not saying to check it so frequently if they're DAT positive from just ABO incompatibility.
Okay, wonderful. Thank you so much.
Of course.
Alrighty, I haven't seen any other hands raised and no other questions in the chat box. So I think we probably are ready to wrap up for this afternoon. I want to thank Dr. Chang again for the great talk and all of you for attending. We will send up follow-up materials in about a week, including a PDF of the slides, as well as a link to the recording of this talk. And we hope to see you all again soon. And I believe this is our last CME for 2024. So wishing you all happy holidays and a happy new year. And we look forward to seeing you in 2025. Have a great afternoon.
Thanks so much, everyone. Happy holidays.